me and making sure I didn't forget that. It's been that kind of a morning. So welcome to the PN2 Module 6 live lecture, and we've got some things we want to go over. I'm going to share my screen. And here's the PowerPoint I use for this. Let me open up my chat. For some reason it closes every time I share my screen and I have to manually open it and move it, which is kind of annoying. But it is what it is. So to start with, we always have some announcements, not too much today. And so I just want to let students know that, you know, in a normal quarter, the drop date for this summer quarter would be August 20th. So it's almost always, I've never seen anything other than the Thursday of week 7. So that would be August 20th. So if you're considering that, please reach out to me and or your academic advisor for some guidance and let us know what your plans are regarding that. I believe the COVID drop is still in effect. So if you feel that perhaps you qualify for that, talk to your advisor about that. I have nothing to do with any of that. Just remember that your proctored exam, for most students, it'll be pharmacology. There are a couple who have already leveled up, so they'll be taking alternative. That's going to take place during the live lecture time of week 8. So from about 9 to 10:30 of week 8. So plan that into your schedule. You have to do it during that time. You can't do it at an alternative time like normally you can skip the live lecture and listen to it recorded. This is not an option for the proctor test. So make sure you have Proctorio loaded and all of that taken care of. And then just letting you know that there is a change in the remediation requirements that has to do with that summary sheet that they added last quarter. We're going to be using that as a cover sheet, but you don't have to fill the whole thing out. So there's information in the ATI resources about that for you. And if you have any questions, let me know. That does not take effect until the proctored for this class. I'm not making you with the practice do it, but I do have to for the proctored going forward. So we have some consistency with that. So if you have any questions about ATI remediation, please reach out to me so I can help you understand what those expectations are. I don't want you to miss out on any points because you didn't understand what was required of you. Okay, any questions about the announcements before I move on to our content? Okay, I'm going to move forward. Maybe I'm going to move forward. Here we go. There we are. So one of the concepts that we're studying this quarter, we covered it during, or you will be covering it during your clinical time a little bit, is gout. And so looking at the drug therapy for gout, there are different medications that we use for acute gout compared to chronic gout to make sure you can identify the difference between the two, or which is in each category. So this is quite honestly a slide you need to memorize as far as which column those medications fall into. Teaching for these medications, make sure that these are taken after meals and with a full glass of water. With gout, it's super important that people who have gout stay well hydrated, but they also need to have that medication dissolved in that full glass of water. So make sure that they know that. And for probenecid specifically, they should not take aspirin with probenecid. So if they're on an aspirin for their heart and they have gout, they need to talk to their doctor about that. They should not be taking both of those. So as I mentioned, drinking lots of fluids while taking these medications, and these do have an effect on the liver and some other labs, so they should routinely get their CBC checked, have their liver enzymes checked, as well as their renal function. So those are kind of some key points about gout. All right, and I'm going to ask people to go ahead and participate in this next slide. So you walk into a room and you see this patient. What are your nursing priorities right now, your interventions?
Call for help.
One at a time. I could hear Ron. I couldn't hear who the other person was. So start with Ron and then the other person can share.
I just said call for help.
Yeah.
The team. Yeah.
Yeah. So what systems do we have in our hospitals for situations such as this? What is it called?
Rapid response.
Rapid
Yeah,
response.
exactly. It's called a rapid response. In all hospitals, I think across the country, they're a regular part of all health systems now. If you're in a long-term care or another type of um, care center, know what it is that's similar to that in your area. So you want to get some help right away. Okay, so get some help. Okay, and so somebody else actually jumped in and was sharing, and if we could have you share what else we're going to be looking at.
Next, you have to assess the airway.
Absolutely. Absolutely. We are going to assess that airway and protect it. If you look at her lips and her tongue, or we can't see her tongue, but we can see her lips and eyes are quite swollen. We expect to see similar qualities with the tongue, which can occlude the airway. So when you get that rapid response, make sure that we get a crash cart or your airway
Yeah,
cart.
break into the crash cart.
Yeah, get that crash cart open and get it ready, because there's a good chance that somebody is going to have to assist this patient with her airway. So I'm seeing some chatting in here for epinephrine, and yeah, we're going to be looking at giving some epinephrine. That's also in your crash cart, probably the fastest place for you to get it. And so we want to get that into the patient right away. Uh, and getting that rapid response. Now, who comes with a rapid response? I'm going to back us up just a little. Who comes?
Usually people from ER and ICU.
Okay, so people as in the
Oh,
cleaning crew, or
no, like doctors and respiratory.
okay, so yeah, we're going to get the hospitalists or intensivists, whoever happens to be on your rapid response team. So you're going to get a physician or a provider there, absolutely. And respiratory therapy is going to come. And you're going to get a nurse from a higher level of acuity. Like if you're on a med surg floor, you're going to get, usually it's an ICU nurse who comes. You also get like your admin supervisor. And so every hospital defines who's on their team. You might have labs show up. They may stay in the background in case you have to draw some labs quickly. They're right there to be able to do it. So so yeah, we're getting that rapid response team there. By all means, stay with your patient. Send somebody else to get that crash cart. Don't leave your patient alone. My expectation is that she's feeling a little anxious right now with what's going on, and your job is to keep her calm so that it doesn't, the adrenaline doesn't have a negative effect on her. All right, so we're thinking epi, so we get that epi, and what other medications might we be considering? Let me get my chat, scroll down. Yeah, Benadryl. We may also be looking at giving some IV Benadryl. Obviously not in the pill form. It does come IV, so we'll be giving both of those. The epi doesn't last very long, so don't be surprised if you have to give additional doses of epi. But then the Benadryl is a little longer acting, so the two together. All right, what else? So steroids, yeah, we may be looking at giving some Solumedrol or prednisone for the steroids, absolutely. What else do you think we're going to be looking at? Yvonne, that's not good. I'm sad to hear that you have to deal with this all the time. That's pretty scary.
Possible intubation.
Okay, so yeah, we're going to be, and someone mentioned that in the chat a little earlier. We've got that crash cart and the intubation cart, if it's a separate cart where you work, right there. So, we're going to be looking at possibly having to do that. And Kay just chatted in IV fluids. Yeah, if you don't have IV access, make sure you get it. Hopefully you have it already. You're going to need that for the epi, but don't delay the epi. If you don't have an IV access, give that epi IM, get it right in there to them. But then we want to make sure we get that IV access, get some fluids going, and then oxygen, very important as well. Absolutely. Anything else that they might want to consider? Is there anything else that can help open that airway? Yeah, so possibly some albuterol.
Albuterol.
Yeah, yeah, and the albuterol won't be the first thing. That's not the most important thing to get the airway open. It's just going to help the whole process. You know, it's the epi is the key thing, and the Benadryl. Those are the key medical interventions. But you know, that airway is our first priority. So everything else we're doing is really to help support that airway. Okay, good. Thank you. Let's see here if I can get it to go. There we are. So we also are studying in this module the human immune deficiency virus, or HIV. So how does the virus attack human cells? Does anybody know what it does? All right, I'm not hearing anything, so that's okay. So we're going to talk a little bit about it. So the virus actually invades the CD4 T cells, and then, okay, so good, and then it replicates itself. And the purpose of the cell used to be to help with immunity, the CD4 T cells. And now once it's invaded by the HIV virus, its sole purpose is just to reproduce. So it takes over, and then all it does is reproduce itself. So that's a really bad thing, because now we've got these cells that are not healthy, that are taking over and reproducing more cells that sole purpose is to reproduce themselves and not to provide infection control. So normal CD4 T cells, anybody know those levels?
That
Two.
over 1,000?
Okay, got some good chats in here, so we'll talk a little bit about, we see some greater than 200. So actually normal, we want those cell numbers to be higher. It's actually 500 to 1600 is the normal range for a person who doesn't have a disease process that's attacking their CD4 T cells. So 500 to 1600 is the normal for that. The less than 200 that we're seeing here, once they go below 200, then we'll talk about that a little bit later, but basically that means they have progressed from just being infected with HIV to the actual AIDS disease. All right, and so what does that initial infection look like? If someone is exposed, that initial exposure that infects them with HIV. Yeah, Yvonne just chatted, and it looks like the flu. So, you know, there's fever, night sweats, chills, maybe headache, muscle aches, a little bit of sore throat perhaps, and a rash. So very similar to pretty much any viral infection that we see out there, or most viral infections until COVID-19 came along. But, you know, and they're often, you know, they're just so vague that, you know, a person might not even realize that that's the virus that has invaded them. And so, you know, it just lasts for, you know, I don't know, about 10 days, I'm guessing 10 days to 2 weeks. And then they go back to feeling normal again. And so they may not even know that they're infected with this virus. All right. And so for diagnosis, a person has to be HIV positive, and they either have to have CD4 T cell count less than 200 that we mentioned earlier, or less than 14%, or an opportunistic infection. So they could be above the 200 CD4 T cell count, but because they have Kaposi's sarcoma or another opportunistic infection, we say that they have progressed into the actual AIDS diagnosis. So, but they do have to be HIV positive for that, not just have the opportunistic infection. And the Kaposi's sarcoma, we typically only see that in our country in people who have HIV, but there are parts of the world where that disease can happen. There's some other genetic things that play a role in that. I think it's around the Mediterranean somewhere they see cases of it as well that aren't related to HIV. So just a little tidbit of information for you there. Not on the test, just a little FYI. Okay.
So, Dawn, that Kaposi sarcoma in our somewhere in our materials that we were given, maybe in the book, it showed like upper torso lesions, but it was my understanding that that generally starts on the feet.
It's a full body. They probably showed the pictures just because the upper torso, particularly on a man, you know, is easy to show. But yeah, I don't know where it, I can't speak to that, Yvonne. I don't know enough about it as far as that, but I know that they get them all over the body. It's not just the torso. So very interesting. You challenge me all the time. Now I want to look that up and find out more about that. So I'm going to make a note. Thank you. All right, so the CDC HIV stages. So, you know, we used to talk about being infected with HIV or HIV positive was one status, and then having AIDS was the next. And so you'll still see a lot of that. But if you're doing any recent research, you may see that now they're talking about HIV-1, HIV-2, and HIV-3. And so they classify it that way in the CDC. So the stage 1 is that acute infection, 2 to 4 weeks is that stage. And then there's this clinical latency stage that we call stage 2. So that's what we used to call HIV positive, because with typically people don't test positive during the stage 1, but with the stage 2, they would test positive for it. But then stage 3 is where they've progressed to the AIDS actual diagnosis, but the literature you see out there may actually say HIV-3. So if you see that, now you have an understanding of what that means. All right, and for HIV testing, the recommendations.
Quick question, Dawn.
Yes.
Couldn't we add to that last slide one more level? Meaning that you have AIDS, but you're non-detectable, like, couldn't that be updated? Because now we've got so much chemicals or so much medication that somebody might have AIDS, but be non-symptomatic and also not be able to transmit.
That's interesting. I wonder if the CDC will update that. Yeah, that resource was from the CDC, but they wouldn't, if it wasn't detectable, they wouldn't have AIDS. They'd be
But
HIV
they're still
positive.
classified as having AIDS.
They are.
Because they're not cured. There is no cure, really. You can be undetectable.
So AIDS is active disease. Remember, I'm going to go back up a couple slides to talk about this. Okay,
but
so
because if you go off your
AIDS,
medications, your levels are going to go back up.
They are.
Or down.
And
right. So you still have AIDS, but
no, they don't have AIDS.
Well,
they have AIDS. You have to be HIV positive and have a count CD4 less than 200. So if their status is such that they can't even detect the HIV virus with the tests that are there, their CD4 counts are going to be above 200. And they're not going to have opportunistic infections or that 14%. You follow me? So they're actually,
I mean, I guess
they're
it's
still in this stage 2. They will be in stage 2 as long as those levels are there. So they still have it, yes. They don't ever suddenly, you know, we're not at a point yet where people are cured. But for them to have AIDS, they have to have those other conditions met. So I don't know, you know, it'll be interesting, Ron, as we the medications.
It's the medical version of AIDS, you know, like what it actually is. But then there's also like you're still on disability. You're still considered AIDS as far as legality, but yet medically you're not. So it's
yeah.
yeah, it's
Yeah, it's very interesting. And, you
yeah,
know,
it's new
it has,
territory.
so and it's, yes, exactly. It's just been in the last couple years that the medications that we have to treat it have been that effective that we can actually see those counts be almost untraceable for
Right.
patients. And so I think the next 5 years, we're going to see, there's going to be even more medication advances, but we'll also see, what happens. Sadly, there will be some individuals who find themselves with untraceable amounts who stop their medications, or we're not going to trial anybody with that. Certainly we wouldn't ask anybody to trial it as a human trial, but we'll get a better understanding of, will we eventually get a cure for this? Where we're at, it's so close, but if they stop their medications, then do they revert back to a
Right, and
decline?
then there's the insurance not paying for the medication because you no longer have AIDS. So then they
Right,
can't take their medicine, then they get AIDS again. It's like,
right, right, exactly. Yeah. All right.
yeah,
So
all right,
okay, so here are our HIV testing recommendations. So annually for those who have repeated high risk exposures. So, know who those individuals are. Basically, if you are having other than monogamous sex with, or, and your partner is also monogamous. So that would be high risk exposures. People who use IV drugs, IV drug users are at risk as well. And so, they recommend that those individuals be tested annually. And then one time between the ages of 15 and 65, or a routine prenatal screening. So, I mentioned in one of my clinical groups when I was in South Africa, every single patient, I worked in a clinic for a week alongside a South African nurse, and every patient who came in who wasn't already known to be positive with HIV was tested for it every time they came in. It was just part of their routine tests. Higher risk factors there than we have in our country, just because of some education and other types of things. But this is what we recommend here in the United States. So, and then there's a variety of different tests. The nucleic acid test, that's probably the most common that we see, but there's antigen antibody combination tests, as well as the antibody tests, the HIV, IgM, and or IgG antibodies. They would detect for those as well. All right. And so healthcare exposure to HIV. So if you were to be taking care of a patient whose HIV status you do not know, and you have a needle stick, what should you do first?
Wash the location for 1 minute and then contact employee help.
Absolutely. So we're going to wash that infected area. If it's not your eye, you want to use soap and water. If it's your eye, make sure you're doing it copiously with water. Absolutely. And you can do what they call bleeding the wound. So, you know how when we check blood sugars on a patient and you kind of milk the finger a little bit to get the blood to come out. If you do that, they say that that is supposed to help reduce the risk of that. So, you go ahead and bleed the wound, wash it thoroughly, and then at that point, once you've washed it, then what's our next step?
You contact the employee health and then they'll start medications.
Yeah, so find out the process for where you work, um, notifying the employee health or the ED. They're going to start to do a little investigation on the patient that was involved to see if there's a known HIV status for that patient, and probably they should test that patient. They're going to start you, unless they know that patient for sure is negative, they're going to start the person who has just had the exposure on the CRT therapy, so medication, within 2 hours of exposure to get the best results. So that's important to know. The sooner you can start someone on the medication, the better outcomes that they have. So once they have test the source and determine the HIV status. If it's positive, they're going to continue that prophylaxis. So it's called post-exposure prophylaxis, or PEP. And so that's the combined antiretroviral therapy. That's the CART I talked about. They're going to get that started. So absolutely within 24 to 36 hours, they want to start that, but they could start it as early as 2 hours. So know the policy of the organization where you're working. All right, the client does have to, I'm not 100% sure about that, if they do have to agree or give consent. That's a good question. I'm going to reach out to my employee health, phone a friend, and ask her. And I'll put that in the FAQs, because that would be really interesting to know legally what's required there, since we do have an exposure to that. All right, so if they're unable to determine it, they're going to recommend that you continue that therapy, that post-exposure prophylaxis, for 28 days, or until the HIV status of the source has been determined to be negative. So they're going to continue it for 28 days. Then they're going to continue to test the employee who has had the exposure for HIV at 1, 3, and 6 months. Okay. So in addition to that, they're going to be keeping an eye on electrolytes and creatinine and a CBC. They're going to check that about 2 weeks after starting the therapy to make sure that the individual is tolerating the HIV medications or the prophylaxis medications pretty well. So that's for exposure to it. So let's talk about the care of the patient with HIV. What's our main priority if we know someone is HIV positive, and especially if we know that they have advanced to the point of AIDS? What's our main priority?
Prevent infection.
Absolutely. So preventing infection is top priority for them. So making sure you're educating them about, things to avoid if they're at risk. And if they're in that stage 2, there's a different level of risk than if they're in the stage 3. So you have to know that. What's another priority for somebody? Let's talk if they have HIV 3. And they've got opportunistic infections that are happening. They show up, let's say, with pneumonia. They haven't been able to fight off pneumonia.
Airway patency.
Okay, so airway patency, but even more so on a cellular level, we're looking at what's a big concern with somebody with pneumonia.
Airborne precautions.
Depending on what type of pneumonia they have. If that type of pneumonia would need to be on precautions, we would, but not everybody who has pneumonia, who has HIV-3, would need to be on airborne precautions. So it just depends on if they had TB, yes. So perfusion, okay, so before we get to the level of perfusion, so perfusion has to do with distributing the oxygen to the cells in the body. What's our concern? The oxygen level, yeah. So we're looking at that gas exchange and making sure that we're promoting or enhancing that gas exchange. So very important. Another main concern of individuals who have the HIV-3 is managing their pain. They have many sources of pain, including neuropathies, a lot of neuropathies that go along with it. So we want to make sure we're keeping them comfortable. And then nutrition. We've often seen images or pictures of people who have HIV-3, and they're often very, very thin. Almost cachectic looking. And so, we want to make sure we're providing for nutrition. So high calories, high protein, but not just high calorie, high fat. We don't want high fat for them. So we're avoiding the dietary fat. And then, choosing small, frequent meals. They often have some nausea going on, and they can't really deal with large meals. So frequent small meals is very important. Diarrhea is a common problem for these individuals as well. Sometimes it's due to an infectious cause, but sometimes it isn't. Sometimes it's related to drug therapy or even lactose intolerance. And so you just kind of have to work with the patient to find out, what precipitates it, what causes it, and what's making it better. So there's not always an effective therapy for that. So helping them to be able to manage their life so that they have a good quality of life with this side effect can be a real challenge. And then, we're looking at skin integrity. So restoring skin integrity as we can. So Kaposi's sarcoma is the one skin condition we talked about already. And we often also see neurological changes and confusions, especially as the disease progresses. And so, working to enhance cognition is important. And then we want to remember the whole of the patient. We want to address any psychosocial concerns they have. This can be very distressing, even if they're not in HIV-3, in HIV-2. Depression can become a big part of this. Anxiety, there's fear. Often people feel isolated and, a sense of loss. They often, loved ones, often are not able to cope with this diagnosis well. And so people who were once very close to them maybe withdraw, and that can leave them needing the support of our mental health team. So make sure that we're addressing those and not waiting until someone is severely depressed before we intervene on their behalf. All right, any questions about either of those things related to HIV? We're almost done here, so we're running just a little over. All right, so I'm drawing your attention to this chart, so be sure you review it. It's chart 19.8, and it talks about infection control for the home care of a person with AIDS, so very important. All right, and any questions for me? I'm going to stop sharing. Any questions? Otherwise, we're pretty much done with what I have for you here today. All right.
I had a question about the assignment, like for Sunday, the videos. We have to upload those
Hang
for
on
our course
just,
project.
no videos. Let me stop the recording here.
Oh, okay, thought you had.